Good morning, everybody. Hope you have a good rest last night. And welcome to the Ramatipudi Hospital's newest facility for soft cadavers and many things in basic science and innovation will take place here at Ramatipudi. Jakuri Narupadin is a very long name. You can call CNMI here in Samut Prakan province. And actually, for the anatomy, I think everybody here, if you pass the exam for medical students, you will know all about this, more or less. But this is like, when you practice, maybe you forget all the basics and the anatomies, and when you're going to do the cadaver or do the surgery, you have to go back to basics for once in a while to review the anatomy and stuff in order to make your surgery more worthwhile and safe. No conflict of interest, but due to my busy schedule, I have to thank Professor Navamon Lexgood for her outline and some parts of the slides for this lecture today. Any question you can ask Professor Navamon. The content of today will be the abdominal wall, because you have to enter the abdominal cavity, and then the pelvic vessels, which we have to avoid, the retroperitoneal spaces, which will be the object of practice this morning. We're going to try to develop the pelvic spaces, identify the pelvic nerve, and end with the ureters. This is the abdominal wall. Everybody knows about that. And this is the level above the umbilicus, and this is below the umbilicus. No, not below the umbilicus, but above the arcuate line. The middle part is the rectus muscles, and the lateral parts are lateral abdominal muscle. I cannot point with this one very well. There's a transverse abdominal muscle, which gives aponeurosis in front and at the back of the rectus muscles, and below the arcuate line. The aponeurosis merged to form only the anterior rectus sheath only. And if you look closely, when you enter the abdomen, in the peritoneum, there will be a small 5 folds here inside, which I will mention about this later because it has some importance to look at during the enter of the ports. To review, this is the vessels that supply the abdominal wall. Actually, from the aorta, abdominal aorta, it branches into common iliac arteries. The common iliac arteries branch into the external iliac artery and internal iliac artery. And if you forgot it, the external iliac artery will pass the inguinal canal and then became the femoral artery. So this is the same one with different names. The inside part is the external iliac arteries. It will give branch to the abdominal wall muscles, and while when it pass the inguinal ligament, it becomes the femoral artery, and the femoral artery will give branches to the small vessels that feed the abdominal skin. So the external part for the skin, the internal part for the muscles, and there are some medial and some lateral parts. Like for the deep vessels, here is the one that we fear most, is the inferior epigastric arteries, which will course medially and alongside the rectus muscle. And if you place the part too medially, you injure the inferior epigastric vessels. And this is the same one when you do the phalansteal incision and you try to lift the abdominal sheath up and separate the rectus muscle from the sheath. Every time it will bleed here, and you can call it the inferior epigastric arteries. And for the skin, after it come out of the inguinal ligament, it will give branch to the superficial epigastric artery here. We will encounter that during the phalansteal incision when you dissect the skin for phalansteal incision. The first one will bleed is the superficial circumflex iliac arteries. And we will also course medially, so place the lateral parts laterally to avoid them. And the further one is the superficial epigastric arteries and more laterally. So I have to be careful of these vessels. And when looking from the inside, you place the scope in, you place the parts in, and then you look, if you could look up, and you will see there are many folds here. This is after the peritoneum is dissected. You will see a total of 5 folds on the abdomen. The middle one is the urethus, which is connected to the bladder over here, and from the umbilicus to the bladder. The lateral ones are the median umbilical fold, which used to be the obliterated umbilical arteries. And that is one important thing, because the obliterated umbilical arteries, when you trace it back to the origin, it comes from the internal iliac arteries. So if you would like to identify the internal iliac arteries, this one is the terminal branch of it, and you can, by pulling it, no one would love to pull it all the time to identify the internal iliac arteries. So just pull this one, but not these ones, because this is a lateral umbilical fold, and you should not pull it, because inside it has this is a fold which covers the inferior epigastric vessels. So you have to look at this and not to try to put your part through the inferior epigastric vessels. And these are the folds of the peritoneum. Oops. The pelvic vessels. As mentioned before, the common iliac arteries branch into the external iliac artery and internal iliac arteries. It gives branches to the middle rectal, to the uterine, to the inferior vesicle, and the terminal one would be the obliterated umbilical artery, and goes to the umbilicus. Remember when the baby is born and you have to check there are 2 arteries in one vein. This is really the vessels of that. And there are some parietal branch for the common iliac artery. The external iliac would go there, like I mentioned before. Actually, it gives the branch here also, like the inferior deep circumflex iliac arteries and vein, which is the border for the pelvic lymphadenectomy here inside. And for the internal iliac artery, you will have the posterior branch would feed the gluteus muscles, and the anterior branch would give branches to the visceral, pelvic-visceral organs. So that was the vessel system. And now come to the thing we have to tackle today, this morning, is the retroperitoneal spaces. There are midline spaces and there are lateral spaces. There are 2 lateral spaces, namely after the place where it's located. Like the paravesical space is next to the bladder, which is a vesicle, and the pararectal spaces are next to the rectal area here. Actually, these spaces are loose and avascular spaces. So it helps when you can notice that the pelvic organs, all of them can enlarge, the bladder can enlarge and then empty, the rectum also, and the uterus also. These retroperitoneal spaces allows it to expand and collapse as much as they like. So this is a relatively vascular plane, and if you can identify these planes, you can do surgery more easily and more safely. When there are resistance, that means something is going abnormal inside. You have to be aware of the bleeding or something that will occur after. So we have to look at the paravesical spaces and the pararectal spaces, and there are 4 midline spaces. This is the prevesical space, or the space of Regis, and the retropubic space. And between the bladder and the cervix is the vesico-uterine space, or vesico-cervical space, depends on whether it's in front of the cervix or in front of the uterus. And the rectal vagina space is between the rectum and the vagina, and the pre-sacral space is the retrorectal spaces. And these are the ligaments that divide the spaces. So to divide the lateral part, which is the tubervesical ligament, both sides, and this is a vesicouterine ligament on both sides. One easy thing is that the names correspond to the origin and the insertion of the ligaments. And this is the retropelar, and this is the anterior and the posterior retropelar. And here are the cardinal ligament or McEnroe ligament, or lateral cervical ligament, the major support. And which is like for right hysterectomy, we have to identify the pararectal and paravesical in order to identify the cardinal ligaments. Inside the cardinal ligaments, you have to know that there are the uterine arteries, and the ureter crosses below the uterine arteries at the McEnroe ligament. And that is the basic one, and we are now going to the more sophisticated one. Like this is the supportive tissue, the ventral supportive tissue, the middle supportive tissue, and the dorsal supportive tissues to divide these planes. The ventral supportive tissue, they contain the vesicouterine ligament, and for the middle supportive tissue, you have the lateral paramedium, the deep uterine vein, and the pelvic splenic nerve also enter at this McEnroe ligament. For the dorsal supportive tissue, this is the uterosacral ligament, hypogastric nerve, which we'll talk in detail later, and the rectovaginal ligament. And please notice that this is not just the pararectal space. This is the lateral pararectal space, and this is the Okabayashi's pararectal spaces. I will talk about it later. So let's look at the paravesical spaces first. The border, the lateral border is the obturator, internus, and levator ani muscles. The medial is the bladder pillar. The inferior is the endopelvic fascia. The superior is the lateral umbilical ligament, and posteriorly is the uterine artery in the cardinal ligament. But actually there's not a single paravesical spaces. There are lateral paravesical spaces and medial paravesical spaces. This is when you open it and open the retroperitoneal spaces, when you divide the down ligament, and then you look inside, and there will be a loose space here that you can, if it's an open surgery, you can walk through by your fingers between the external iliac artery and the obliterated umbilical artery, and then next to the uterus, and then push your finger downward, and it will go down there easily to the pelvic wall, to the lower pelvic wall. But if it's a laparoscopy, you have to use your blunt instrument to create the spaces. For the lateral paracervical spaces here, and this is the one which will make the identification of the lymph nodes here easier. You can identify the vessels here easier by developing the paravesical spaces here. This is the lateral one. Posteriorly is the lateral pararectal space, which I will talk about later, and the borders are over here. You can look at it after the lecture. And for the lateral this is the paravesical spaces, and this is, I put it, the names wrong. This is the medial paravesical space. The medial paravesical space can create, when you look at the previous slide, this is the obliterated umbilical artery that I mentioned before. If you cannot identify for the external iliac artery, it's so easy. It's the largest vessel that pulsates and superficially, but medially it's the internal iliac vessels and medial umbilical arteries. The obliterated umbilical artery would be somewhere, and in the middle of the active planes and things. If you cannot find it, you can identify the median umbilical ligament that mentioned before, and you can pull up the median umbilical ligament, and it will show the obliterated umbilical artery, and then you push it. When you push it medially, you will identify the lateral paravesical spaces, and you develop the spaces. After you have the lateral vesical paravesical spaces, you can now push the obliterated umbilical artery laterally, and there you will find the medial paravesical spaces inside. By developing this space, you can identify more easily the uterine arteries and vein and the cardinal ligament. And this is very useful for radical hysterectomy. For the pararectal spaces, at first it seems easy. It's a lateral one, which is the lateral border is the levator ani, the medial are the rectal pillars, the posterior is the anterolateral aspects of the rectum, and the anterior superior is the peripheral part of the cardinal ligament and uterine artery, anterior and superior. But this is not just a one single pararectal space. To complicate things further, there are two ways and two methods for identifying the pararectal spaces. This is the Latsko pararectal spaces, which is the large one like I pointed out before. But actually, if you can identify the hypogastric nerve and push it laterally, you can identify the Okabayashi's pararectal space, which is medial to the Latsko's pararectal space. This is Willem Latsko. He's an Austrian gynecologist who died in New York in 1945. Whatever, and he invented some urogynecology procedures, which the urogynec might know very well. But however, regarding the lecture, he's identified the pararectal space. This is the relatively easy one. This is just behind the uterine artery, medial to the internal iliac artery, and the body here is the ureter. And if you push the ureter away, this is the pararectal space. However, Professor Hidegasu Okabayashi is a professor from Kyoto, Japan. He identified that actually there are two approaches to approach the pararectal spaces. Some call it the endometriosis approach and the oncology approach. The endometriosis approach will approach it from medially, like from the IT ligament, infundibulopelvic ligament, and approach it near to the first thing that comes out would be the ureter. That is the endometriosis method. But for the oncology method, we will open it lateral to the infundibulopelvic ligament and then move it medially, and then the first thing when you saw it would be the external iliac artery, and then approach it, the pararectal spaces from laterally. That is the oncologic approach, which makes surgery for a specific task easier. And this is for Okabayashi. Remember the last one, this is the Latsko. The Latsko, the borders are here. The difference between the Latsko and the Okabayashi is that you identify the ureter and the hypogastric nerve, and then try to push it laterally. Retract the ureter, and if you can find the hypogastric nerve, which hopefully you can find it today with a soft cadaver, and then try to push it away, and the entrance to the Okabayashi's pararectal space will be over here, next to the uterosacral ligament here. And this is the hypogastric nerve, and this is the ureter. This is the Okabayashi's pararectal space. And this is to compare between the two. This is the Latsko pararectal space, which is more lateral, and with a hypogastric nerve medially. And this is the hypogastric nerve and the ureter at the same connective tissue layer with the ureter and the hypogastric nerve. So if you can find one, you will be very talented and lucky today. And if you find that, the one medial to the hypogastric nerve is the Okabayashi's pararectal space.
ខ្ញុំថតហើយ convert ទៅដែរ
The last toe is here. But if you would like to connect with the Okabayashi and last toe, you have to break the hypogastric nerve, which is not good for the fertility preserving surgery for the external cancer. This is the Okabayashi space. This is our last toe pararectal space. Here. And this is ureter and obturator nerve. Okay. Like for the, I'm sorry, I didn't realize that there will be some urogyne here, so I just prepare most about gynecology oncology, so it's more like for gynecology oncology, but just for your general knowledge, for those who are not involved in oncology. For like, if you would like to preserve the hypogastric nerve, you have to isolate it like here at the same place as the ureter, right? And mobilize it away with the ureter over here. And like this is on the cadaver, it's injected dye. This hypogastric nerve, it envelopes the rectum along with the pelvic plexus and the pelvic spine nerve here. Yeah.
black box
So paravesical, pararectal, and this is the last pairs are the paravaginal spaces. This is necessary for radical hysterectomy, but this is for general knowledge for those who are not involved in oncology. So in order to preserve the nerve, the hypogastric nerve, you can see that the course of the hypogastric nerve goes down from here and then give two branches, one to the cervix and one to the bladder here. And you like to try to cut this without interfering the branch that goes to the bladder. So if you can identify, there are two ways to identify it by Okabayashi, and this is so there are two Okabayashi pararectal spaces, and this is the Okabayashi paravaginal spaces, like below the cervix area. This is the space, and this is covered here by the dorsal layer of the vesicouterine ligament. And to cut that, you have to identify the Okabayashi paravaginal spaces before cutting these part, the vesical veins of the dorsal layer of the vesicouterine ligament, and there you can preserve the branch of the hypogastric nerve that goes to the bladder. This is one way. The other way is the Yabuki's fourth space. This is the Okabayashi paravaginal space, and this is the Yabuki's fourth space. You can notice that these two pictures are different at the ureter. Like for developing the Okabayashi spaces, the ureter will be retracted laterally and posteriorly. But for developing the Yabuki's fourth space, this is medial to the ureter, and the ureter is not mobilized from here. So it's another approach for approaching that, but the concept is the same, is trying to preserve the branch to the bladder of the hypogastric nerve as much as possible. And this is the star here is the Okabayashi's paravaginal space, and the O here is the Yabuki's fourth space. So you have to cut over here so that this morning you can try your hands at identifying this space. And the pelvic nerve, I'm going to go into detail with the pelvic nerve, because if you are not going far enough, you wouldn't approach the pelvic nerve anyway. But the general knowledge is that there are the superior hypogastric plexus coming from here and forms into the hypogastric nerve, and this nerve becomes a pelvic plexus and goes to the urinary bladder and to the uterus. This is a gross statement. And there are some things that you will identify also is the obturator nerve. Obturator nerve is from upper part from L2, L3, and L4, not S1, and then goes here and go into the obturator space, and you can identify the obturator nerve also this morning. And this is the lumbosacral trunk from the lower lumbar to the upper sacrum and give rise to the lumbosacral trunk here. And the obturator is the posterior division here, and the lumbosacral trunk is from the lower lumbar and upper sacral area. I wouldn't go into detail about the nerves because I think this is too far beyond, but if the urogyne would like to expose it, please ask them because I'm not accustomed to the nerves either. And lastly, for the ureter, because this is our worst enemies, we don't want to cut it to them. So actually, there are only a few places where a ureter can be transected, and everybody, as a gynecologist, know about that. Is the place where it crossed the bifurcation of the common iliac into external and internal iliac. Over here, it right next parallel to the infundibulopelvic ligament. So we have to identify it before cutting the infundibulopelvic ligament. And it goes down and cross water under the bridge. It goes below the uterine arteries and enter the bladder. And this is very important either for abdominal approach or laparoscopic approach. As I always tell the trainees who doing the uterine manipulation, the uterine have to be pushed as upward as much as possible. Either is abdominal approach, you have the assistant to hold the uterus as upward as they can, and if it's a laparoscopy, you have to push the uterine manipulators inside. And in some model, there are some cuff that will extend push the uterus upward. To the purpose of pushing the uterus upward is to separate the uterus from the ureters. The more upward, the more further of the uterine arteries to the ureters, and you can cut it more safely, and you can enter the vagina more safely. And this is the only main point that have to be kept in mind for take care of the ureters. Yes. And here, the more upward the uterus, the more upward the ureter goes with the uterus, and then you can transect the uterine artery and the cuff more safely. And this is my final words of the day. Everybody have their own final words of the day, so this is mine. You have to know your enemy. Because you are doing the battle, you have to know your enemy. You don't want to enter into the rectum, you don't want to enter into the uterus, so you have to be careful about the courses of everything, and you have to know your terrain, which is normal and which is abnormal. So when it is abnormal, you can identify the structures more properly, and then confused, get back to the basics. The anatomy is the truth for everything. With the pathology, any pathology, there will be some truth in the anatomy, so go back to the basics. And for the knowledge retention, you have to, in order to know, to remember everything, you have to teach others. So when you go back, you might lose memories of all the lectures, but if you keep on teaching, especially during the operation, if you teach your medical students, every time you enter a vessel, you call it by the name, or if you forget, you can ask the medical students around, look up, what is it? And then you don't remember by yourself. And then look up, yes, this is this vessel. The more you teach, the more you can remember about the structures and things. But that is for knowledge retention, but for skill retention, you have to practice, and practice. And some surgeons will have a fear because like pelvic spaces, there are lots of vessels that can cause detrimental fatality to the patient. So this is, the more you know about your enemy and your basic anatomy, the more confidence you will have and overcome your fear. And the soft cadaver here are dedicated, it is dedicated by the patient themselves. So this is not for commercial. And this is the very good place to learn anatomy for today. And let's make the donation from the patients worthwhile today by learning as much as you can. Take this opportunity to explore any things you dare not do to the real patients, and you can explore it today and take it take the experience in as much as possible. And for the reference, if anybody interested in nice pictures, you can look at this journal here, International Journal of Gynecology Cancer. Here there are lots of beautiful pictures and text for you. So enjoy the day. Thank you.
Thank you very much, for a well-rounded lecture on the topic. I'm sure we'll get to use all the knowledge during our workshops. And as a token of appreciation, the RTCOG would like to give Professor Arun